Hi everyone, welcome to our second webinar in our oncology series. Tonight we'll be having a talk on symptom control in oncology by Taufik Hairudin. Dr. Hairudin's an ST7 in Clinical Oncology in Tayside, and 4 out of 5 junior doctors in Tayside agree he is their favourite oncology reg. So over to you when you're ready, Taufik.
Thank you, Joey. I'd quite like to know who's that 1 out of 5. Not happy about that. Anyway, hello everyone and good evening. My name is Taufik Hairudin. I am a clinical oncology specialist registrar and I work in Niwell Hospital in Dundee and Tayside. So today, first of all, we'd like to thank the organizer, the team from Mind the Bleep for approaching me and giving me the opportunity to do this talk. To do this webinar. I hope this talk will be useful for everyone, particularly junior doctors and if there's medical student, because as mentioned on the website, whether you are interested in oncology or not, looking after patients with cancer will be an inevitable part of your job. So regardless of whether you're going to do medicine or surgery or GP or any other medical specialties, you will encounter cancer patients. And I hope this talk will be relevant because we estimated that half of the population will be affected by cancer, half of the UK population. So either they have cancer or they had cancer or they're being investigated for suspicion of cancer. So like it or not, you will encounter patients with a history of cancer. Okay. Right. Now, I don't know if any of you have been to any oncology talk or any oncology teaching. Normally in talks or lectures about oncology, there will be a lot of statistics involved. There will be charts, there will be data, there will be Kaplan-Meier curve flying about, endless p-values, hazard ratio and all that. But fortunately, or unfortunately, depending on which way you're looking at it, I have none of that. The only thing that will resemble any statistical data would be me saying phrases like statistically speaking or most commonly or in comparison. That's all the statistic that you're going to get from me. Otherwise, I'll do my best not to bore you with any statistics. My talk is very simple and I hope it's very relevant and very practical to your day-to-day job. Okay. So let's start then, shall we? This is an oncology talk. We're talking about cancer or cancer symptoms. So this is my obligatory slide of the hallmarks of cancer. I'm sure you've seen this before. If you haven't, this is it. The hallmarks of cancer suggest the complex mechanism and interactions of how a cancer is developed. Initially, in the year 2000, it is thought that there are 6 features which allow cells of our own body to go rogue and become cancer. Then more research were done, and then we realized that there were 8, and then there were 10. As you can see on this slide here, there are actually 14 hallmarks of cancer. I'm not going to bore you with each and every one of these, but the reason why this is relevant is because some of these hallmarks of cancer or features are the reason why patients develop symptoms from their cancer, especially features like evading growth suppressors, enabling replicative immortality, activating invasion and metastases, and resisting cell death. Okay. So the hallmark of cancer, what it tells us is that the nature of cancer is they want to grow. Okay, and they want to spread, they want to metastasize. So nothing is going to stop cancer from growing unless you do something about it, i.e. you treat the cancer. So patients develop symptoms because cancer grows, and they grow within organs, within structures, and they cause pain, they cause fragility, which can lead to, for example, pathological bone fractures, and they can grow and cause obstruction, which lead to symptoms like pain, vomiting, and so on. And when they grow, they can also cause pressure, which why you get symptoms from malignant spinal cord compression, why you get symptoms from SVC obstruction and raised intracranial pressure. Okay. Now, I also said that cancer will continue to grow unless you do something about it. So we treat the cancer with either surgery or radiotherapy or SACT. So you're going to hear me say SACT a couple of times, SACT, which stands for Systemic Anti-Cancer Treatment. In the past, we only have surgery, radiotherapy, and chemotherapy, whereas nowadays, if you look in the red box there, these are some of the systemic treatment that we use to treat cancer. It's not just chemotherapy. It's getting more exciting treating cancer nowadays. So to make things simpler, I will say SACT rather than just chemotherapy or just immunotherapy. Now, these systemic treatments, particularly radiotherapy or SACT, they're technically they're poisonous, they're toxic. Sometimes, ironically, some of these patients were not that symptomatic from the cancer, but they become very symptomatic to a point that would affect their quality of life because of cancer treatment, not because of their cancer. So cancer treatment itself can lead to symptoms and sometimes can be quite severe, even life-threatening symptoms. I've seen a patient who had chemotherapy and then died from severe diarrhea. This is on cytidine before we do DPD testing. So it's really important to consider that if they're on cancer treatment, sometimes the symptoms not due to their cancer, but due to the cancer treatment. Right. Okay. Very rarely, cancer can also be poisonous in inverted commas. This is more commonly known as paraneoplastic syndrome, which is a lot of time it's a diagnosis of exclusion. Cancer itself is not poisonous, but sometimes they release hormones and peptides or cytokines, or they can interact with your immune system or with our immune system, which can lead to symptoms. Hypercalcemia is probably the most common one that we see. Having said that, hypercalcemia due to extensive bony metastases, which is not a paraneoplastic syndrome, is more common than hypercalcemia due to paraneoplastic syndrome. So again, bear in mind, paraneoplastic syndrome, yes, it can happen, but it's a rare thing, and a lot of the time it's diagnosis of exclusion. Finally, when talking about symptoms in cancer patient, we also need to remember that they can also develop symptoms which are not related to the cancer, or sometimes not even related to the cancer treatment. So brain metastases can cause headaches, we know that, but patient with brain metastases can also have migraines, which causes headaches as well, and it's not related to the cancer. So please remember, just because they have cancer, it doesn't mean that all of their symptoms are due to cancer. Occasionally, it's not due to cancer. Occasionally, it's something unrelated to the treatment. Okay, so as I said, my talk is going to be very simple, hopefully very straightforward. What are the principles of treating or managing symptoms in cancer patient? Rule number 1, treat the symptoms or stabilize the patient. Now, this sounds a bit daft. Like, why would I say rule number 1 of managing symptoms in cancer patient is treat the symptoms? That's the title of the talk, not really the solution. I might as well just, have this slide here. There we go. Here are my presentation. There we go. If you can read that, then you can deal with cancer patient. Sometimes it's not as straightforward. But what I'm trying to say is that sometimes we're so caught up on the cancer. We say that they have cancer, so we have to treat the cancer. Yes, we do have to treat the cancer, and a lot of the time their symptoms are due to their cancer. But we forget to actually treat the symptoms or stabilize the patient first. Managing symptoms in cancer is the same as managing symptoms in patients without cancer. You need to alleviate the symptoms first, investigate the cause, and then you need to treat the cause. So even if somebody without cancer, you would do the same thing. You do that that's the protocol. Well, not the protocol. That's what you normally do. They come in with pain, you treat the pain, and then you investigate what causes the pain, and then you treat the cause of the pain. Yeah. But remember, you don't have to wait until the patient's symptoms are totally gone before you investigate. But at least you need to put some effort to make the patient feel more comfortable, and then you investigate. I'll give an example. Imagine if you have a 60-year-old man with a history of heavy smoking and alcohol intake, and also a history of poorly controlled diabetes. This man presented with essential crushing chest pain associated with breathlessness, sweats, nausea and palpitations. You suspected that the patient might have a myocardial infarction. So what do you do first? You wouldn't just pick up the phone and say to the cardiology registrar that I think this patient has had a heart attack and you need to take him to the cath lab immediately because he needs PCI. The cardiology registrars then ask you, what are you doing about his pain? Have you given him antiemetic for the nausea? If he is breathless, is he on oxygen? Have you done an ECG? Have you checked his troponin? So on and so forth. I'm sure if you haven't done any of those, you're more likely to get your head bitten off by the cardiology registrar rather than get helpful advice if you refer a patient without managing the symptom first and then do the investigation, if you know what I mean. If there is any cardiologists in this talk, my apologies. I'm not saying that you're a horrible person. I'm just using this scenario as an example. Okay. Right. In real life, my day-to-day job as an oncology registrar, I've lost count the number of times when I was referred a patient for consideration of radiotherapy for pain control. And then when I asked what analgesia had the patient been prescribed, the answer is paracetamol. And not even regular paracetamol, just PRN paracetamol. And no wonder the patient is still in pain. So please remember, alleviate the symptoms as best as you can first. And then you investigate the cause, and then you treat the cause. Symptoms due to cancer or cancer treatment can be very severe and sometimes very complex as well. So remember, palliative care team. So referral to the palliative care team often needed in cancer patients, particularly when it comes to pain, when it comes to complex nausea and vomiting, and also end-of-life care. The other thing about palliative care team, you have to remember that they don't just support patients who are for palliation or patients on palliative treatment. They also support patients who are on radical or curative treatment. Okay, right. Now, let me move forward. To that. Okay, so I'm going to talk about specific oncological treatment. So one of the main reasons for treating cancer is to improve the patient's symptoms. Okay, so it makes sense if cancer is the cause of the symptoms, then we should use specific oncological treatments such as surgery, which includes, resection or stent placements, radiotherapy or SAT. But these treatments, while they can be very, very effective, can take time to organize, and then it takes time for them to work. So, for example, if I give palliative radiotherapy to a patient for pain control, one, I have to organize it first. I have to get in touch with the radiotherapy team and stuff. The patient will need a planning CT scan first. We can get it done all within one day. There's a 75% chance that it would work, but it can take up to 1 to 2 weeks for the patient to notice that their pain is better after the radiotherapy. So these specific oncological treatments such as surgery, radiotherapy, or SAT could be the ultimate solution because they treat cancer, but not the immediate solution. So your patient might still be suffering, your patient might still be in pain, your patient might still feeling sick. So you have to treat the symptoms, okay? Right, before we go on to specific symptoms which is associated with cancer or cancer treatment or common in cancer patients, a special shout to steroids. We in oncology, we love steroids. And the reason there's a special shout about steroids is not just because we love them, because steroids is very, very versatile. And we prescribe bucket loads of steroids. We use them as antiemetics, very, very effective. They are anti-inflammatory as well, so we use them to reduce swelling around cancers. In hematological cancers, especially lymphoma, steroids are actually part of their SAC, part of their anti-cancer treatment. And steroids can give patients energy boost, and they boost the appetite. It doesn't work for everyone though. But it does help to majority of our patients. And when we go through some of the common symptoms in cancer patients, you will see that I will be mentioning steroids again and again and again and again. However, we do know that steroids is not the magic pill. Unfortunately, steroids can lead to horrendous side effects, which can lead to more symptoms. Ironic. Unfortunately. Right, okay, so these are the symptoms that I'm going to go through. Okay, I'm going to start off with pain, nausea, vomiting, fatigue, and anorexia. So these are sort of general symptoms, and we see them quite a lot. And then we go from like system to system, from head down to your gut, to your lungs, and then abdomen and pelvis. Okay. It's not going to cover all the symptoms, obviously, but if you have encountered symptoms which I have not mentioned, feel free to ask, and I will try my best to answer those questions. Okay, right. I have got a few scans in my presentation because I like looking at scans. I'm not a radiologist, but it's part of my job to actually look at scans because I do radiotherapy. Right. The image on the images on these slides are from the same patient, both sides. Yeah. It's a patient that I saw recently. The sagittal image on the left showed a soft tissue mass. Vertebral body, I don't know how clear you can see that. L1 and T12, and you can see the mass has grown into the spinal canal and it's causing spinal cord compression. And spinal cord compression can be really, really sore. The images on the right, the one on the top, it shows what a normal spinal canal should look like. You can see there's a dark gray structure in the middle of the spinal canal. That's the spinal cord, and the spinal cord is surrounded by this white area, which is the CSF. The image below of it, it's the same patient. It's further down the patient's spine. You can see that there's mass growing into the spinal canal from the vertebral body, and there's barely any CSF around the spinal cord. So this mass is actually pressing on the spinal cord. And as I said before, spinal cord compression can be extremely sore. I've got more images. On the left, I don't know if you can see, it's a patient of mine with recurrent metastatic breast cancer. You can see there's a soft tissue mass in the left axilla or near the supraclavicular fossa. You can compare it with the other side. So the mass is pressing on her brachial plexus and her vasculature, so it's causing neuropathic pain to the left arm and also lymphedema. The image on the right is another patient of mine, metastatic breast cancer as well, widespread bone metastases. Unfortunately, she had a fall and she sustained a pathological fracture of her left tibia. Even just looking at that image, you'd be thinking, oh, that looks really sore, right? Okay, so let's move on. So we're going to talk firstly about pain. Probably the most common symptoms you had to deal with in cancer patients. Remember rule number 1, treat the symptoms. So treat the pain, give them analgesia. Okay, I'm sure everybody has seen this. It's the analgesic ladder. You start off with non-opiates such as paracetamol. You might want to give some non-steroidal such as ibuprofen and naproxen, provided that there's no contraindication. Then you go up the ladder. You add in weak opiates such as codeine or tramadol. Then if the pain is still not well controlled, then you go on to strong opiates such as morphine, oxycodone, hydromorphone, or fentanyl, depending on what they normally use in your hospital. Most of our cancer patients are going to be on the top of the ladder. Cancer pain is quite severe, so a lot of our patients are on strong opiates. Okay. A few things I would like to mention though. When you prescribe weak opiates like codeine or tramadol, please only prescribe one of them and not both of them. Never prescribe codeine and tramadol together. If they're still sore, for example, you prescribe them codeine and they're still sore, you increase the dose of codeine rather than adding in tramadol. If they're still sore despite maximum dose of codeine, then you go up the ladder and introduce strong opiates. I've seen patients being prescribed codeine and tramadol together. That doesn't make sense to me. Because they have the same mechanism of action. So it's the same principle as prescribing proton pump inhibitor or PPI for patients with heartburn or acid reflux. If they're on omeprazole and they still have heartburn, you increase the dose. You don't add in lansoprazole on top or alongside the omeprazole. That doesn't make sense, okay? And the other thing is, once you are on the top of the ladder, do not prescribe weak and strong opiates together. If they're on MST, for example, or Zomov twice a day, and you use Oromov for breakthrough painkillers, right? But don't use codeine. If they're on MST, use Oromov. If they're on oxycodone, long-acting, use oxycodone, short-acting. Okay. Right. So once you give them analgesia, once you give these patients with pain analgesia to at least take the edge off their pain, you start to investigate the cause of the pain and then you treat it. If they sustain a pathological fracture, for example, then they will need referral to the orthopedic team. If they didn't have a fracture, but they have bone pain due to bony metastases, then sometimes bisphosphonates can help, either pomidronate or zoledronic acid. If they have obstruction, such as bowel obstruction or urinary retention, then you need to release the obstruction. Steroids can sometimes help because steroids can reduce swelling around cancer. But they may need surgery or procedure to release the obstruction, such as laparotomy, catheterization, or stenting. Okay. Remember, pain in cancer patient can be quite severe, so getting the palliative care team involved can be very helpful. Please also remember that cancer patient can also have pain which is not related to their cancer, such as migraine, heartburn, osteoarthritis, and so on. Right, that's pain. Here I've got a picture of one of the patients I've seen recently with spinal cord compression. The patient who I showed you the MRI before, so that's the radiotherapy plan for this patient. I'm going to talk briefly about radiotherapy and pain. I mentioned this before. Radiotherapy can be very effective, and I give a lot of radiotherapy for pain control. And 3/4 of patients who receive radiotherapy notice that their pain is much better after radiotherapy. There's a 25% chance that it won't work, though, unfortunately. And radiotherapy causes inflammation, so we usually warn our patient that their pain can potentially get worse temporarily before they get better. And as I mentioned before, the effects of radiotherapy can take 1 to 2 weeks to work, so it's very important that you try and manage the symptoms with medications, analgesia first, before considering radiotherapy for pain control. Okay. Next symptoms, nausea and vomiting, again, very common, either due to cancer, but sometimes more commonly due to their cancer treatment, chemotherapy particularly. Remember, rule number 1, treat the symptoms, give them antiemetics. On this slide are the list of antiemetics that we quite commonly use for our cancer patient. I'm sure you would use a lot of these for non-cancer patients as well. Again, a couple of things I'd like to mention and like to remind you, never prescribe metoclopramide and domperidone together because they're both prokinetic, so they have the same mechanism of action. Never prescribe, you either prescribe one or the other, and never prescribe metoclopramide and cyclizine together because they have opposing mechanism. If you try metoclopramide, it doesn't work, stop the metoclopramide and then start them on cyclizine instead, or do it the other way around. There we go. Once you've treated their symptoms, investigate the cause. You will see a pattern here. So treat the symptoms, investigate the cause, and then treat the cause. You investigate the cause. So if it's bowel obstruction, it's very common in our gynae patient, particularly ovarian and primary peritoneal cancer patient. They can develop subacute bowel obstruction. Steroids can be helpful. But obviously, if they develop mechanical obstruction, they would need surgery. If surgery is not feasible or patient's not fit for surgery, sometimes we do start the patient, or commonly we start the patient with a syringe driver with steroids and prokinetics like metoclopramide. This combination can be actually very effective. But be careful though, as you need to investigate first and make sure that they do not have mechanical obstruction before starting them on metoclopramide. If the nausea and vomiting due to chemotherapy or radiotherapy, dexamethasone and or ondansetron can be very, very effective. If the cause of nausea and vomiting is their chemotherapy, sometimes you do have to stop their chemotherapy. If they're sick or they're nauseous or because of increased intracranial pressure because they got brain metastases and there's lots and lots of swelling around the brain metastases, steroids can be very helpful because steroids reduce the inflammation around the cancer and can reduce the swelling and release some of the pressure in the brain. Okay. Again, nausea and vomiting could be one of these symptoms that could be very difficult to manage, and you may need the help of palliative care team. And I'm going to keep emphasizing this. Don't forget other potential causes of nausea and vomiting, such as UTI, gastroenteritis, reflux, and everything, and so on. Okay, right. Next, fatigue and anorexia. Again, very common. When I say anorexia, I don't mean anorexia nervosa, that eating disorder. It's more anorexia is the lack of appetite. The patient's not eating because they haven't got appetite. Most of the symptoms that I'm going to talk about, or the two that I've talked about today, I will say rule number 1, treat the symptoms. But fatigue and anorexia, they're different. Fatigue and anorexia are not really, there's not really a treatment that can quickly alleviate these symptoms. So you may need to investigate the cause and treat it. Okay, so in this case, you might have to go straight to finding out why they're fatigued and why they're not eating and drinking properly. Sometimes though, a lot of the times, we in oncology would use steroids to boost their appetite and energy. It can be very effective, but it doesn't work for everyone. And remember those horrendous side effects of steroids. But once you've found the cause, then you have to treat it. If they're fatigued because of their cancer, we need to treat their cancer. If it's due to cancer treatment, you might want to either stop them, provide supportive measures such as steroids and nutritional support, or reduce dose. Sometimes patients are so fatigued with their cancer treatment that it affects the quality of life so much to stop cancer treatment altogether. If they have pain, treat the pain. A lot of people don't realize that being in pain is exhausting, absolutely exhausting. So it's important that you treat them. If they have poor appetite and weight loss, or if they have high MUST score, I don't know if you heard of MUST score, MUST. What's MUST again? Malnutrition Universal Screening Tools. I think if they've got a MUST score of 2 or above, patients need to be referred to the dietitian to see if they need nutritional support. Steroids can sometimes help with appetite. How many times have I steroids on this slide alone? Do you see what I mean when I say we love steroids, right? The other thing about fatigue and anorexia, when patients approach end of life, they will have fatigue and anorexia. So if you investigated the patient and you can't find any other cause of fatigue and anorexia apart from progression of their cancer, and you can't do anything more for their cancer, then there's no point in trying to reverse it. Just keep the patient comfortable and communicate to the patients and their relatives so that they know what is happening and what you're providing end-of-life care to keep them comfortable. Again, this is another situation where you might want to refer to the care team. Right. Oh, more scans. Great. On the left is an MRI scan of a patient with, initially, she had a locally advanced lung cancer and she was finishing her radical treatment when she got a metastasis. Then reported that she had been experiencing early morning headache, nausea, so her head, and the MRI showed a mass in the occipital lobe, which is very unlucky, with surrounding vasogenic edema. I think, I don't know if you can see the edema or the swelling around where you see a dark grey area around where the cancer is. So the cancer is in the occipital lobe. On the right, an MRI head of a patient of mine with metastatic triple-negative breast cancer. It's a solitary metastasis at the pineal body or the pineal area of the brain, and it's causing a degree of hydrocephalus. So this patient presented with headaches, visual disturbances, and poor balance. She is going to start her radiotherapy I think on Friday. So, headaches and other neurological symptoms. Again, rule number 1, treat the pain, treat the symptoms. So treat the headaches, okay? If the headache is due to brain metastasis, so you then investigate. If the headache is due to brain metastasis with a lot of edema or a lot of swelling around the cancer in the brain, then steroids can help reduce the swelling, and you might want to consider definitive treatment for the brain metastases, either with surgery, radiotherapy, or SAT. If they have leptomeningeal disease, or sometimes we say leptomeningeal carcinomatosis or meningitis carcinomatosis, this is when you have metastases in the meninges, the lining of your brain and your spinal cord. It's an awful disease if patients have leptomeningeal disease. The diagnosis is not straightforward either. Usually CT head doesn't normally show anything. The MRI head can sometimes show some meningeal enhancement, but a lot of the time don't. And sometimes you need to do a lumbar puncture to confirm the diagnosis. I had a patient once when I was working down south in England. I had a patient who was really and extremely sore and agitated. CT was normal, MRI was normal, so we had to get help from anaesthetic to do an LP. And CS sample showed malignant cells, which confirmed diagnosis of leptomeningeal carcinomatosis. And as I said, her CT and MRI scan was normal. So, leptomeningeal disease can be very, very sore, and patient can be very agitated up to a point that if they are approaching end-of-life care, sometimes the most humane thing you can do is to knock them out with lots and lots of opioids and sedation. It sounds horrible, me saying that we just knock out the patient, just make them unconscious with lots and lots of medication. But I remember when I was a junior doctor, when I was working in Aberdeen, I saw a patient with metastatic melanoma who you could hear him shout and howl from the end of the corridor because he was so uncomfortable and so agitated. So we had to pretty much sedate him with lots of morphine, lots of midazolam, because it was just terrible for the family to see their relatives suffering like that. It was horrible, but you don't. But it's the most humane thing you can do. Finally, remember again other causes of symptoms which could be not related to the cancer or the cancer treatment, because other causes of headaches and neurological deficit. For example, patient can still have migraines. They can still have tension headaches. If cancer patients developed any sudden onset neurological deficit, it's more likely that they had a stroke or a bleed rather than metastases, because brain metastases tend to grow slowly rather than rapidly and causing rapid or sudden onset symptoms. Next, I like this one, status epilepticus levetiracetam. So I'm going to talk about seizure. So seizures, I said that we love steroids, and in the context of brain metastatic vasogenic edema, steroids can reduce the swelling and reduce the pressure in the brain. But if they had a seizure, you need to start them on anti-epileptics, okay? Because anti-epileptics is the thing that will prevent further seizures or reduce the risk of them developing new seizures. Steroids only reduce the swelling. Eventually, cancer will grow, so you do need to start them on anti-epileptics. And like the meme that I showed you just before, Keppra levetiracetam is usually our epileptic of choice as long as there's no contraindications. So treat symptoms first. Okay, lorazepam if you need to stop seizures, anti-epileptics to prevent further seizures. You can also add dexamethasone if on the scan there's evidence of lots of swelling in the brain. Then obviously if the patient is fit enough and the patient has brain metastases, you treat the cancer. Okay, surgery, radiotherapy, or SAT. Next symptoms, mucositis, sore mouth, or oral thrush. These symptoms, the sore mouth, mucositis, oral thrush, almost exclusively a result of cancer treatment rather than cancer. So a lot of times it's iatrogenic rather than because of cancer. Patients can develop mucositis when they're neutropenic after recent chemotherapy. High-dose radiotherapy to the head and neck. Patients with tonsillar cancer, for example, they get high-dose radiotherapy to the head and neck. They can develop mucositis as well. Immunosuppression and prolonged use of steroids, because we love steroids so much, they can also cause oral thrush. So while with other symptoms, treating the cancer can help the symptoms, not when it's mucositis or oral thrush, because these conditions develop due to the cancer treatment itself. Okay. It doesn't mean that if they have mucositis, you have to stop the cancer treatment. It means that you must support them with, mouthwash and antifungal. So the mouthwash that we normally use, Difflam, Cafsol, use antifungals such as nystatin. Sometimes you can use gel clear as well. You need to investigate if they've got ulcers or infection, because sometimes they can get herpes simplex infection, and that can cause a lot of mouth ulcers and can be quite sore. Right, next we've got, sorry, my slides are so, scans, good. On the left is an image of a normal scan. It's a normal CT scan. This is really difficult. I've not got a cursor to show you, but if you can see posterior to the trachea, you can see where the esophagus is. So the esophagus looks really small, but that's what a normal esophagus usually looks like on an axial CT scan is. The image on the right, the top and the bottom. The top is a PET scan, the bottom is the CT scan of the same patient. If you look at the bottom image, you can see the esophagus is thickened. So there's this soft tissue mass, and it suggests that there's a mass filling the lumen of the esophagus, and the image on top is a PET scan. Again, of the same patient, and you can see there's an uptick, so it looks bright. It looks that bright yellow color in the middle of the scan is actually high metabolic activity, which is likely due to cancer. And in this case, it is due to cancer because it's proven with a biopsy. that's images of patient with esophageal cancer. Dysphagia, rule number 1, treat the symptoms. So if they are sore, give them analgesia. If they're dehydrated, give them IV fluids. You might want to refer the patient to the dietitian, as they may need artificial nutrition such as energy feeding or TPN while you investigate and while you treat the cause of the dysphagia. Okay, can you see a theme so far? You've got symptoms, you treat the symptoms, you stabilize the patient, then you investigate the cause, and then you treat the cause. Although it's not 100% correct. For example, like fatigue, it doesn't normally works that way. But anyway, if the dysphagia is due to cancer, treat the cancer. Treat the cancer. If it's due to radiation stricture, which can happen if they have radiotherapy to their esophagus, then they may need a dilatation or a stent. If they had radiotherapy recently and you think they might have radiation esophagitis, remember radiation causes lots of inflammation and they can have esophagitis secondary to the radiotherapy. Steroids might help. If they have oral thrush, then give them antifungal. And remember other causes of dysphagia as well. Right. Haematemesis and haemoptysis, again, rule number 1, treat the symptoms, stabilize the patient. Their symptoms usually due to cancer itself, either in the upper GI tract or in the lung. Sometimes we give them chemotherapy, we make them thrombocytopenia, and they can develop haematemesis or haemoptysis of that. So treat the symptoms first, stabilize the patient. If they're vomiting, you might want to give them antiemetic. If they're anemic, you might want to transfuse them. If they're sore, obviously give them analgesia. Then obviously you need to try and stop the bleeding or prevent further bleeding, either endoscopically or medically using tamic acid, for example, or PPI if you think they've got haematemesis. Or occasionally a single fraction of therapy can be used for hemostasis. Once you've investigated the cause, then treat the cause. If it's cancer, again, treat the cancer. If it's thrombocytopenia because they've had chemotherapy recently, then you might want to give them some platelet transfusion. Right. Next slide is more scans. Slides on the left, or image on the left, is a patient with a metastatic neuroendocrine carcinoma of the lung. You can see there's a massive mass in the mediastinum, and it's growing on into the right lung. You can see, I haven't got a cursor, but it's different. You can see the arch of aorta there. Okay, that's on the left side, but on the right side, which is on the other side, you can see the SVC is actually being compressed. So this patient is actually developing SVC obstruction, and the patient presented with breathlessness and also swelling in the face and hoarse voice. The two X-rays on the right are of the same patient. The patient had immunotherapy as part of her lung cancer treatment. She was in the hospital, cough and shortness of breath. X-ray on the top showed these widespread opacities compared to the previous X-ray, which is the one secondary to her immunotherapy. So an example of how cancer treatment can cause problems, side effects, toxicities, which can lead to symptoms. Right. So breathlessness or shortness of breath. Rule number 1, treat the symptoms. Obviously, if they're breathless, then give them some oxygen. And then investigate the cause. If it's due to the cancer, obviously treat the cancer. If they've got lymphangitis, so lymphangitis is inflammation of lymphatics in your lungs. Cancer, one of the hallmarks of cancer you see is that cancer causes lots of inflammation. That's why you get a lot of swelling with cancer, around cancer, because there's a lot of inflammation around cancer. With inflammation, you get better swelling. So lymphangitis can make the patient quite breathless. Steroids can be very helpful, but ultimately, if the lymphangitis is due to the cancer, you do need to treat the cancer. Patient can have pneumonitis, like the X-ray that I've showed. Pneumonitis is inflammation in your lungs, so you give them steroids to help with the inflammation, and you stop the culprit drugs. More often than not nowadays, with our cancer patient, they develop pneumonitis because of immunotherapy. I don't know if you've heard about immunotherapy. Immunotherapy is different from chemotherapy. Chemotherapy goes into your body and then it attacks the cancer. Immunotherapy, on the other hand, they work like a middle person. There's a theory to say that each and every one of us have got cancer, or developing cancers in our body, but our immune system is clever enough to find these cancer cells and attack them and destroy them. When somebody gets diagnosed with cancer, is when they've got cancer cells that grows. It's usually because these cancer cells have become clever, so they've managed to hide themselves from your immune system, or they manage to present themselves as if they're part of your normal cells. So your immune system will attack these cancers. Immunotherapy works by telling your immune system that these are cancer, you have to attack the cancer. So they work by boosting your immune system, so your immune system knows these are cancer, attack the cancer. When they do that, immunotherapy can sometimes make your immune system go on a bit of an overdrive. So you get symptoms, you get autoimmune symptoms because your immune system attack your own normal cells. That's why they can get pneumonitis. So if you ever encountered a patient who got a history of lung cancer or any other cancer and they're on treatment, they're on immunotherapy and they come in with breathlessness, then you might want to think about, could they have pneumonitis, for example. If they did have pneumonitis from either their X-ray or the CT scan, they need to give them hydrosteroids to dampen down the immune system. Cancer patients and patients on cancer treatment are at high risk of PE. So if you investigate and you find out they've got PE, then you need to start them on anticoagulation. Remember other causes of shortness of breath, for example, pneumothorax or heart failure, pulmonary edema, and patient cancer. Cancer patients, just because they have cancer doesn't mean that they can't have other causes of shortness of breath. Okay. Next symptoms. More scans. So scan on the left, the two scans on the left are of the same patient. This patient with, again, metastatic breast cancer. Picture the image on the bottom, you can see the patient's pelvis, and you can see lots and lots of bowels and maybe some feces in the bowels as well. But the image on the top is the same patient a few weeks later. This patient has got peritoneal metastases. You can't see the bowel much. What you can see is all this grey fuzzy area, and that's ascites. So this patient presented with abdominal pain, abdominal distension, because she's got lots of ascites in the bowel. Image on the right, you can see on the top is a man with sigmoid adenocarcinoma. So this man presented when I was on call one day with abdominal pain. And vomiting. Obviously, a patient can develop vomiting or nausea because of the chemotherapy, and he was on chemotherapy, but I did an abdominal X-ray, and you can see that he's got a distended transverse colon on the abdominal X-ray. So we did a CT scan, which confirmed that he's got bowel obstruction because of a stricture in his sigmoid colon because of the cancer. So this man ended up having a colon to release the obstruction and improve his symptoms. So when it comes to abdominal or abdominal distension, again, rule number one, treat the symptoms. They're in pain, you give them painkillers. And treat the cause. If it's cancer, obviously you need to treat the cancer. One of the main causes of abdominal pain in cancer patients, particularly those with liver metastases, you can get liver capsular pain. Your liver sits in a capsule, so if they've got lots and lots of cancer, that stretches the capsule, and that can be quite sore. You can give them analgesia. Steroids can be very helpful in these patients. If they've got ascites, then you might want to drain the ascites. If they've got obstruction, again, they might need surgery, or if they're not fit for surgery, sometimes steroids can be helpful, usually. And remember, other cause of abdominal pain, abdominal distension, they could have gastroenteritis, for example, that can cause abdominal pain. I think this is diarrhea, constipation. Again, treat the symptoms. If they've got diarrhea and constipation, if they got diarrhea, they're dehydrated, give them hydrates. If they've got pain, give them analgesia. If they're constipated and it caused them a lot of pain, again, analgesia. And then you investigate the cause. If it's treatment related, for example, a lot of chemotherapy causes diarrhea and constipation, diarrhea more so than constipation. Then you might want to treat them with supportive measures, IV fluids sometimes. Once you rule that it's not gastroenteritis or infective gastroenteritis, then you can give them the IV fluids, and sometimes you can give them, not IV fluids, you can give them loperamide to try and slow down the diarrhea. Patient can develop colitis either from chemotherapy or nowadays more commonly from immunotherapy. Radiation can cause colitis as well. So colitis by definition is inflammation. So anything that ends with the itis in the end, we normally treat with steroids. So you can give them steroids, or you can stop the treatment if it's the treatment that caused the colitis. Again, if the cause is cancer, then treat cancer surgery, or radiotherapy. And remember other causes of diarrhea and constipation. Right, I think this is going to be the last symptoms I'm going to talk about. A couple more scans on the left. If you look at the patient's right kidney, there's a mass. In the right kidney, this is a patient with renal cell carcinoma. On the right, you can see that's a CT urogram. You can see there's thinning defect in the patient's bladder. There's a mass in the bladder wall posteriorly on the right side. That's a patient with transitional cell carcinoma or urothelial cell carcinoma of the bladder. Right, so hematuria and other urological or urinary symptoms, again, treat the symptoms. If they're sore, give them painkillers. If they're bleeding, stabilize the patient. And then you investigate what causes their symptoms to be obstructed. They might need to be catheterized because they've got urinary retention, or if they've got hydronephrosis, which sometimes can cause a lot of pain, flank pain, for example, might need a stent or a nephrostomy. If it's the cancer that's causing the bleeding or the pain, sometimes we can give radiotherapy for hemostasis or for pain control, or we can give chemotherapy or other systemic treatment to treat their cancer. If they're bleeding because recently they had chemotherapy and thrombocytopenia, again, you might want to give them platelet transfusion and then wait for a few days. Hopefully their platelet counts will then start to improve. Remember, other causes of hematuria, for example, urine infection and usually cause hematuria. Right. I think that's all the symptoms I'm going to talk about. As I say, I've not covered all the symptoms, but if there's anything you want to ask, please do. But in summary, symptoms in cancer patients can be caused by cancer itself or cancer treatment, but they can still develop symptoms not relating to the cancer or cancer treatment, so remember that. Whilst oncological treatment such as radiotherapy or SACT can be very, very effective in treating cancer and alleviate symptoms caused by cancer, they take time to be organized and they take time to work. So it's very, very important to remember that, like any other patients that present to you with any symptoms, treat the symptoms, stabilize the patient first, then investigate the cause of their symptoms and treat the cause. And also remember, palliative care team, they can be very, very helpful, especially in trying to manage cancer patients with complex symptoms. So that's me.
Thanks so much, Taufik. If anyone's got any questions, please just pop them in the chat. I'm also going to be posting a link to the feedback form in the chat. Really appreciate if everyone could fill that out for Taufik. No questions yet? Okay, I'm just going to pop a link to the next webinar in the series as well. Feel free to register for that one if you're interested, everyone.
I'm just going to go to the last slide because that's no talk on the 15 digits. Yep.
Okay, we'll hang on for a few minutes. If anyone's got any questions, just pop them in the chat. On the other side there, you can also see a QR code for the feedback link if you can't click the link in the chat. Taufik, I have a bit of a general question. Which symptoms do you feel are most poorly managed by kind of your typical doctors on the ward?
I missed that. So which symptoms that normally poorly managed, you say?
Yeah.
Pain. It's the most common, and I would say it's the most poorly managed because, um, uh, I mean, it's easy for me to say this because we use morphine all the time. I'm not saying that. I'm saying that we're very gung ho, but because we use it all the time, day in day out, we're a bit braver in doing that. And as I said before, it's quite common when I get referred a patient because they've got pain because of the cancer, and they wonder whether we should give this patient some radiotherapy. I go and see the patient, look at their cardiacs. They're only on paracetamol, either PRN or even just regular paracetamol. They haven't got anything else, and you see the patient suffering. Or the patient's in agony. The patient can barely talk to you because they're sore. So I think pain is number one. I think one of the benefit of me when I was a junior doctor was my rotation was oncology. So I did 4 months oncology in Aberdeen, and we worked very closely with palliative care team. I think and palliative care teams are so lovely. They're so nice, and I learn a lot from them. And that's how I got to be brave in managing pain. I mean, I think partly why it's so poorly managed is probably because people are not comfortable with stronger painkillers. Sometimes, I did say in my presentations, some of these pain control issues can be quite complex, so you might want to speak to the palliative care team. But sometimes you do need to put a bit more effort in terms of managing their symptoms. Don't just say, oh, they've got cancer, they've got pain, let's speak to oncology, let's speak to palliative care team. And then when we come and see the patient, they're only on paracetamol, PRN, nothing else. So, I think, yeah, the short answer to the question, I think pain is probably one of the symptoms that I think are poorly managed. And it's not just anywhere else, even in oncology, sometimes that is the case. And even in oncology, we do ask a lot of help from our palliative care colleagues.
Thank you, Taufik. Not seeing any other questions come in yet. We can just hang about for a couple of minutes, and then if there's no other questions. All right, I think we'll end it there. Thank you, everyone, for attending. Thank you again, Taufik, for a very interesting talk. And if everyone could please fill out the feedback forms, that'd be really appreciated. Anything you want to add, Taufik?
No, not really. Anyway, I'm glad there's no questions. Not very good answering questions, but yeah. But no, as I said, I've not covered all of symptoms that we deal with, particularly in cancer patients. So, but hopefully, the ones that I've covered are the common ones, and hopefully, as I said, these are helpful. They're very straightforward, and then there's no complicated statistics or anything like that I've shown. It's more, a lot of them is actually common sense. And hopefully for junior doctors out there, you won't be too anxious or scared when you get presented with a cancer patient and they've got symptoms. Treat like any other patient, manage the symptoms, do as best as you can, and then investigate and then treat the cause. But if you have any questions, sure, get in touch with oncology or get in touch with palliative care team teams, very lovely, really nice. Oncology registrars normally really nice. Well, they're not as nice as me, but yeah. But hopefully the presentation has been very, very helpful. So yeah, I've got nothing else to say.
Right, thanks again. Okay, everyone have a good evening. We'll end